Shall we start soon?
Okay, thank you. So welcome all again, and welcome to this another session on the embryology. And let me tell you that it is the final session for the embryology part. So we have taken 4 sessions. This is the 5th session, and in this session we will be talking of mainly the systemic embryology, right? Where we are discussing the systemic development. So today we'll be focusing on few systems like respiratory system, kidney, and placental circulation. Also very important topic. Hi everyone, welcome. I am Dr. Ankit, your anatomy educator in our Auricle platform, and these sessions are useful for both the university prof exams as well as the MCQ preparation or your national level competition exams. And below you can use the code Dr. Ankit 20 for discounts. Let me just go through it. Please, as always, take the screenshot of this so you can see what are the type of questions that can come in university exams, like long, short essay, and short answer questions. Why to choose Auricle? Here are all the benefits. And just to briefly describe them, this is the recorded classes, live classes, your exam module, doubt clearing notes, Q bank, practical sessions, and all that. I urge you to download the Auricle app so that you have a good idea of what's going on, and all the latest medical news is also there. Now, these are the plans over here. You can see the foundation plan for 3 months, advanced learning plan for 6 months, complete learning plan for 12, and ultimate MBBS for 4 years. You can use the code for various discounts. Okay, so now moving to the topic and for our discussion. Let's move to the discussion now, and this is where we left in the previous session. So I hope you guys are revising. And the previous session we talked about this oral cavity development, and I urged most of you to at least revise about the midgut rotation part, right? Because it is one of the most common questions that is asked about the development, right? Okay, just a second. Fair enough. So let us discuss some midgut rotation, and then we will come to the notes part. First of all, some concepts. So we are into the gut part. Okay, gut. That is our whole GIT, gastrointestinal tract, that is simply known as gut. Few points before going into the midgut rotation. Gut normally is divided into 4 parts. So there are 3 main parts: foregut, midgut, hindgut. But yeah, some books, even your Langmans, also includes the pharyngeal part of the gut. So there is pharyngeal part of the gut, oropharynx, laryngopharynx, this behind the oral cavity. Then there is foregut. Okay, the upper part of the gut, which includes mainly esophagus, stomach, and the initial part of the duodenum. Then we have the midgut part. Midgut, which mainly includes the distal part of duodenum, but mainly includes jejunum and ileum and your ascending colon, that comes under midgut. The hindgut over here, it represents the distal part of the transverse colon, the descending colon, the sigmoid colon, the rectum. They come under hindgut. So yeah, these are different parts. So just a brief idea, foregut is from where to where. Just let me write. It is up to what? Up to the middle of up till the middle of second part duodenum. Midgut is from the second part duodenum to proximal 2/3 of. So it is up to, let me write up to over here, proximal 2/3 of transverse colon. And hindgut is up till the upper half of anal canal. Upper half of anal canal. Now, if you remember yesterday or the previous session, we discussed that at very few places in our body, there is ectoderm indirectly contact or touch with endoderm. This is one of the parts, anal canal. So upper half of anal canal, this is a part coming from midgut. And mind you, all this gut is endodermal. All this gut is endodermal. And therefore, the distal part, the distal half or distal part of the anal canal, that was ectoderm. That was ectoderm. And one more thing, which you will learn more in your gross anatomy, that at the junction of the upper half of anal canal and the distal half of anal canal, where we had that cloacal membrane, okay, that line is also known as the dentate line or pectinate line. So that junction between the endoderm part of the anal canal and the ectoderm part, okay, that is dentate line or pectinate line. Do remember that. Okay, so whole gut is coming from endodermal. You have to understand this part. The gut is coming from endoderm. Right now, foregut, midgut, hindgut, why are they given different names also? Because their blood supplies from different vessels. Like for example, the foregut, I'm writing foregut, midgut, M for midgut, H for hindgut. The foregut will get its blood supply from which artery? Any idea? These are all the branches from the abdominal aorta. The foregut get its blood supply from the celiac trunk or celiac artery. The midgut gets its blood supply from the superior mesenteric artery. The hindgut gets its blood supply from the inferior mesenteric artery. Simple as that. These are the three blood vessels. So they supply the part of the gut. Pharyngeal part of the gut is just the upper part, or you can say the pharynx part. Okay. So understand these are the parts of gut. Now, what actually happens is if you look at the whole gut over here, there's a small thing which we have to understand. And what is that? As I said initially, that it is endodermal. Now, if you remember this previous discussion, we had three layers like a concentric ball, as I gave you an example. And where was endoderm? It was most inside. Okay, it was most inside. Or if I just go with the second or third week, then if you remember, then that we had the ectoderm, and we had the mesoderm, and we had the endoderm. I'm making from the same color just to save the time over here. And then they all they all rotated, and they formed this three concentric layers. They formed this three concentric layers. The innermost was endoderm. We are focusing on endoderm. Now, why I'm doing this, I'll let you know. We'll understand it simultaneously. Now, what was the cavity below? If you remember the week 2, epiblast, hypoblast, the cavity below was yolk sac. Okay, the cavity above was the amniotic cavity. Now this much is clear. Therefore, I said the main part is the beginning part. So when it gets folded, what will be the cavity in touch with endoderm? The cavity in touch with endoderm is the yolk sac. So cavity in touch with the endoderm is the yolk sac. Outside cavity, we have what? I'm just writing amniotic in this manner. Amniotic cavity is lying outside. Inside, we have yolk sac. Is that part clear? Now see what is happening. Inside we have the yolk sac and endoderm. Now this endoderm is giving rise to gut. Now we all know that the gut is quite long. It has very big length. Okay, it is very big length. It is much more. It is many times the entire length of the human body. Therefore, human body, we say the 6 feet is a normal guy, about 5'10", whatever it is. So this entire length of the gut is many-fold. Okay, it is multiple times. So what is happening is that the gut gets fold on itself. And during development, what will happen is that though as endoderm is lying inside and the gut is having so much of development, then what happens is that the middle part of the gut, that is the midgut, middle part of the gut, that is the midgut, the body of the developing embryo is not big enough to accommodate the enlarging gut. I repeat myself, the body of the developing embryo or the abdominal cavity of the developing embryo is not big enough to accommodate the developing gut, because gut is developing at a much high speed. So what will happen? What will happen is that at around week 6, that part of the gut, mainly midgut, because it lies in the center, it comes out into the yolk sac. Why yolk sac? Because yolk sac was the one which was in communication with the endoderm. At week 6, it comes out. Then it has to wait for around 4 weeks, around week 10 or week 11. So what happens in 4 weeks? Now in 4 weeks, the midgut, which was increasing in size, because midgut is mainly what? It is mainly jejunum and ileum. And we all know that jejunum and ileum are considerably quite longer compared to colon. So in 4 weeks, the jejunum and ileum, which are enlarging or increasing in size, they are now enlarging outside the body of the embryo. Where? In the yolk sac only. So in 4 weeks, they will also enlarge, but in 4 weeks, the abdominal cavity of the embryo is also getting bigger in size. So after 4 to 5 weeks, the body reaches its sufficient size so that it can accommodate the gut, the midgut. And it is around week 10 or week 11 that this midgut, which went outside, it now returns back. It now returns back. I hope you got the point. It now returns back. Where? Back into its proper abdominal cavity. So for 4 weeks, where it was? For 4 weeks, around 4 weeks, week 6 to week 10, for 4 weeks, our whole midgut was lying in the yolk sac. It was safe in the yolk sac. But after 4 weeks, then it returned back. Now, when it returned back, when it starts to return back, it is at that time that there is a rotation, Because see, it is not a small thing, it is a long tube. Because long tube is going out and then tube is coming back. So in going out and coming back, obviously there is ought to be some amount of rotation. Now that rotation is known as a midgut rotation. Now that rotation is mid-gut rotation. I hope you got the point. Mid-gut rotation. And just to tell you, for some single line of questions can come, or they can ask in viavos, how much does the midgut rotates? The straightforward answer is it is 270-degree anti-clockwise rotation. How much? 270 degrees anti-clockwise rotation. It happens in 90 degrees of three different phases. 90 degree, 90 degree, 90 degree. It happens in these three different phases. And it is due to this rotation. Now, if you look at the adult, gut, let me try to show you. Then let me try to show you the adult gut in the form of diagram. So this is, imagine the esophagus. Just have a look. This is the stomach. Okay. Now this is the duodenum, first part, second part, third part, fourth part. I'm just changing the color so that we have some less confusion. And then let us say this is the coiled jejunum, and then jejunum continues into ileum. Okay, there's ileum now. Let me change again color so that we have a good idea. Then we have this appendix and cecum, and we have this ascending colon, right? And then we have the transverse colon, and we have the descending colon, and we have the sigmoid colon, and the rectum, and the anal canal, all that. So this is our gut. Where is midgut? Midgut is particularly this orange color, and let me include the ascending colon also. This also is midgut only. Let me just try to add this. This whole is midgut only. Ascending colon and the proximal two-third of transverse colon. So now you can understand, looking at the length of fore, mid, and hind gut, the midgut is the lengthiest one. Second thing over here is that it is due to this normal 270-degree anti-clockwise rotation. Okay, that the artery which is supplying the midgut. Now, what was the artery supplying the midgut? Artery was superior mesenteric artery. Now, due to this rotation, what happens is that this artery lies in front of duodenum. It is due to rotation, and it lies behind the transverse colon. Understand this. The artery, therefore, the duodenum lies retroperitoneal, and artery, superior mesenteric artery, goes in front of duodenum. And transverse colon lies in front of the artery. So basically, it is duodenum, then artery, then transverse colon. Transverse colon is more anterior compared to duodenum. Duodenum is more posterior, and between these two, we have a supramesenteric artery. It is due to 270-degree anti-clockwise rotation. Now, anti-clockwise, we all know, we have seen the watch. If I make a watch for you guys over here, 12, 3 o'clock, 6 o'clock, 9 o'clock. This is the clockwise. So obviously, what is anti-clockwise? Obviously, opposite this one. This is a dot clockwise, anti-clockwise. So now, but many times people confuse that it is from which side. It is from which side that this whole rotation is happening. It is, if you are looking at the embryo, then it is from this side only that the rotation happening in this manner, 270 degrees. Now, sir, okay, fine, but this is a fact. What to do with this knowledge? I mean, what is there any clinical implication? That should always be at the back of your mind while learning anything in medical. At the back of your mind, at the end of the topic, it should always be in your idea or in your thought that what is the clinical application of this knowledge, because you are not living in the college for your whole life. You will be in college for a few years, then you have to move out of college into the real world, to the real people, right? How it's going to benefit you in that. So what happens is there are a lot of malrotation cases which will come to you in form of pediatric cases also. There will be incomplete rotation. Patient will present to you, or suppose you are doing a CT scan, contrast CT scan, or simple investigations. Then you might see, okay, there's some problem, but that could be a normal variation. Or if you are doing a surgery, then you should be aware, okay, that these malrotations are there. So there can be non-rotation. There are so many. Yeah, this clinical implications: non-rotation, malrotation, incomplete rotation, reverse rotation. Okay, there's a reverse rotation also. The rotation occurs in a clockwise manner. A lot of things can happen this way. So we have to understand why it happened, the theory behind it, why it is happening, you should know, and what normally happens, that you should know, so that you know what is abnormal. See, guys, one thing, in first year, your entire 3 subjects, you should be confident of what is normally happening inside the body. This is a must know. Only because this will be your goal in your rest of your life. Once you know what is normally happening in the body, then from second year, you will be learning what is abnormally that can happen. How will you judge if something is abnormal? Only if you know what is normal. Okay, if you know, okay, table has 4 legs. A normal table, if you look, has 4 legs. Normally, most of the tables have 4 legs. So you should know it. Tomorrow you see a table with 3 legs. I mean, that's a different design, but I'm just trying to say, if tomorrow you see a table with 3 legs, you know it is not normal. On 4 corners of the table, there should be 4 legs. Tomorrow you see a table of 3 legs, but if you haven't seen in your entire life a table of 4 legs, you won't be saying that this table with 3 legs is something abnormal. So you should know what is normal. This is the whole idea, right? So moving back to the discussion over here, let us come to this point of the notes. So after the formation of midgut loop, okay, lies around the abdominal cavity of embryo that passes near the umbilical spine. Okay, so there is a pre-arterial segment, there is a post-arterial. Now, what is pre and post-arterial segment? That is also very simple to understand. See, we have that this as the, let me change the color. This is the midgut loop over here. This midgut loops comes outside. This is midgut. So what is the artery supplying it? What is the artery supplying midgut? Is superior mesenteric artery. So it is due to this that this segment before SMA, it is known as pre-arterial segment. And basically the jejunum ileum will come into this part. While this post-arterial segment, what will come? Basically the distal ileum, ascending colon, transverse colon, they will come. So post-arterial, let me write over here what comes into it. Distal ileum, A dot colon is ascending colon and proximal part of T colon. And what comes in pre-arterial? The jejunum, yeah, and majority of the ileum. But only the distal ileum is in the post-arterial. So loop has a pre-arterial and a post-arterial segment. Initially, the loop, the proximal segment lies cranial, midgut undergoes rotation. So there are 3 phases. You have 90-90 degree rotation of 3 phases. You can just walk through the notes later on. Okay, but this is the image which I wanted to show you over here so that you have some more better idea and understanding. Just give me a second so that I can just move it like this. Okay, right over here. So let us see what is the stuff over here. So midgut 1, 2, 3, 4 numbering are given. So you can see that we have the superior mesenteric artery. This forms the axis. Can you see this? This arrow, this is the artery over here. It is forming the axis. Now this will be the pre-arterial segment and that will be the post-arterial segment. So color difference shown for pre and post-arterial segment. Pre-arterial is slightly reddish and post-arterial slightly greenish or bluish. Now you can see over here how the loops are happening from 1 to 2, 90-degree rotation. So this is coming to this side and this is going to this side. 90-degree rotation, first 90-degree. Okay, then you see over here more 90. So these arrows are showing you the rotation happening. And finally, as you can see, that this post-arterial segment, which was mainly forming what? Colon, comes in front of the pre-arterial segment, which was the initial part was duodenum. Therefore, and in between these two lies which artery? Lies this artery, superior mesenteric artery. This is a normal rotation. Okay, so do remember this figure, 270-degree anti-clockwise AC rotation. At least this should be at the tip of your tongue. If suppose the topic comes like a midgut rotation, then this should be very clear to you. Okay, so remember the midgut rotation, it's very important. Now let us come to the pancreas over here, development of pancreas. Before moving to development of pancreas, in a notes manner, let me just tell you a few things over here which you must know. What is that? That is that we have seen about the development of gut. Gut is coming from endoderm. Now listen very carefully for at least 1 minute. Suppose this is the entire gut. I'm making the straight vertical 2 lines. This is the entire gut. It is endodermal. When we see, now guys, one more thing, when we say endoderm, it is basically the lining epithelium, which we are saying that it is endodermal. The entire gut cannot be endodermal. What if I ask you what inside the gut is not endodermal? What in the wall of gut is not endodermal? Then it would be your smooth muscles. The smooth muscles, okay, of the gut. Peristalsis happening with the smooth muscles. The connective tissue, they are all mesodermal. So when we say the gut is coming from endodermal, we are basically referring to the lining epithelium. 1 point. Now I told you about foregut, midgut, and hindgut. Fair enough. But it is not just fore, mid, and hind which are coming from endodermal, but their derivatives also. Now, what will be the derivatives of the gut? So here another point: the derivatives of the gut. It will open your mind and increase your understanding. The derivatives of the gut are the parts or the structures in our body which are directly connected to the gut. If you start from above, this is the esophagus. Is there any other structure which is in direct contact with the esophagus? Or let's say pharynx, because pharynx, then esophagus, no? So is there any other structure in the neck, if I'm giving you a hint, which is in direct contact with the pharynx? Then you will say, yes, sir, there is a laryngopharynx. So there's larynx, and larynx is a part of respiratory system. And bingo, you got it. So over here in the pharyngeal part of the gut, we have the respiratory diverticulum. And it gives rise to the entire epithelium of larynx, trachea, bronchi. So now your question will come, then, sir, is the lining epithelium of the respiratory system also endodermal? And it is yes. The answer is right. It is also endodermal, END, endodermal. Now you come down, esophagus, is there any connection? No. Then stomach, no. Then you go to the duodenum. Is there anything which is directly connecting to the duodenum? Any structure, any tube which is directly opening to duodenum? You say, yes, sir, there is common bile duct which comes from the liver. Yes. So therefore, you have the hepatic diverticulum over here. Which diverticulum? Hepatic diverticulum. It gives rise to what? The entire liver and the whole extra hepatic biliary apparatus. Then your same question, sir, is it endodermal? Yes, it is also endodermal. Then you say, sir, but there are also pancreatic ducts. Yes. So there's a couple of pancreatic bud also. So we have the pancreas also. Pancreas is also coming from endoderm. Endoderm. Okay. Then as you go down, then you have jejunum, ileum. There's any connection? No. Then there is appendix connectivity. Appendix is a part of gut only, so we don't take it separate. Then there are no other diverticulums like that which are coming from it. Got the point? So if you know this basic idea, you know that okay, the respiratory system, the whole liver and extra hepatic biliary apparatus, which actually includes your gallbladder, common bile duct, hepatic duct, all of it, your pancreas and pancreatic duct, they are actually coming from endoderm only. They are actually coming from the endoderm. As you will go down, you will realize, okay, here is an opening of the anal canal, but you will see that in front of anal canal, there is, you'll see later in embryology, there is known as urogenital diverticulum, urogenital sinus, we can call it as. So this is giving rise to what? Just to your extra information, this whole structure, urogenital. So it gives a part of urinary system. Now you will say, but the urinary system, we discussed that kidneys are coming from mesoderm. Yes. But are kidneys alone enough for the whole urinary system? No. Then what else is there in urinary system? You have the urinary bladder. Yeah. So urinary bladder is mainly endodermal. Understand this here only. It is mainly endodermal. It is not connected to the anal canal, but yeah, actually here the septum comes and divides it, and then for anterior part forms the urinary sinus. You have this. Then any genital part also, yes, you have genital part also which is coming from endodermal. Like the vagina, some part of the vagina is coming from endodermal. Okay, they also come from endodermal. So you have these structures. Understand this. So a topic came in our notes as development of pancreas. So you know by now, okay, that pancreas, its epithelium is coming from endoderm, because it directly opens into endoderm. So you don't have to cram or mug up anything. It's simple common sense that if you apply, you will reach the answer. So here we come to our notes part. So pancreas develops from two endodermal. See, it is already writing endodermal buds. So one is in front, known as ventral bud. One is in behind, that is known as dorsal bud. So you have two buds over here. And then they will all form different structures. But come to the image. Anatomy and embryology best understood by the image. Here you will see that there's a stomach over here, and below stomach we have this. I'm writing DOUD, so you know what we are talking about for duodenum. You have this VPB. What is VPB? Is a ventral pancreatic bud. It is ventral pancreatic bud, and DPB obviously is a dorsal pancreatic bud. These two buds, they fuse to form the entire pancreas. How do they fuse? Is see what happens is ventral pancreatic bud. Now this will go behind the duodenum, and slowly it will come over here, and it is going to fuse with the dorsal. So this is the ventral pancreatic bud. And as it is rotating around the duodenum, no, behind the duodenum, this ventral pancreatic bud, as it is rotating behind the duodenum, it takes away along with it this whole CBD also. See, so therefore CBD also you will see opens into this area only. You remember hepatopancreatic your ampulla of Vater? Yes or no? So where the CBD, where the common bile duct opens, the main pancreas is also opening over here. So you have this major pancreatic papilla over here, and both the CBD and your main pancreatic duct, they're opening at the same place. How? Because this ventral bud took along with it. Now, why is this knowledge important? Again, if it does not go around, okay, then there will be common variations, anomalies in the development. And you know how common is the gallbladder surgeries, liver surgeries, pancreatic cancers, pancreatitis. There are so many things. And if you only know, okay, this happens fine, and okay, I know only this and only this happens fine. But if you don't know embryology, then how are you going to judge the variations? Suppose you only know anatomy, okay, pancreas lies like this and CBD is coming, okay, fine. Suppose you operated on 30, 40 patients, everyone they had a normal anatomy, fine. But that 31st patient came and had some variations. Now you'll be surprised what to do. This is something abnormal. So variations you must be, not just for operation, I'm saying, but for general investigations also. And as you will, as we will discuss more, you will learn more, you will see that there are many diseases which are directly linked to the variations. There are many types of pancreatitis. Few patients are more prone to develop pancreatitis because they have some variations. So suppose pancreatitis is not a very good disease to have. It is having a good mortality also. Let me tell you, not a good news for anyone to be diagnosed as having pancreatitis. But yeah, some patients are more prone to develop pancreatitis because normally it is said that alcoholic patients and patients who have gallbladder stones, these are the two most common determining factor or causes of developing pancreatitis. But there are patients who don't have a history of any alcohol, or they don't have any gallbladder stones, but they might have some of the congenital variations. Okay, so diseases are directly linked to variations. So here you're seeing this ventral pancreatic bud. Now it is going back and it is reached over here. And finally, we have this gross anatomy of the pancreas. Now let me show you the pancreas gross anatomy. Okay, let me use the PPT over here. Okay. Now I will try to show you the gross anatomy of pancreas. Okay, how does the pancreas looks like? So pancreas actually appears like somewhat like this over here. It appears like this. Gross adult anatomy. This is the head of pancreas. The small part over here will be known as the neck of pancreas. This will be the body of pancreas, and this small part will be the tail of pancreas. And the small part below over here, let me use a different color. Sorry. Yeah. Color. Let us try to see if we can get the black one over here. This over here, this part is known as the uncinate process of pancreas. This is the entire developed pancreas. But how much of it is coming from the ventral bud and which part is coming from the dorsal bud? This you should know. Let us use a simple highlighter over here, and we will understand it better, that this uncinate process over here and the lower part of the head of pancreas. Only this part is coming from where? Only this part is coming from the ventral pancreatic bud. Ventral pancreatic bud. So ventral pancreatic bud gives rise to, let me write, U dot process and lower part of head of pancreas. Rest of the pancreas, it is basically coming from dorsal pancreatic bud. So what is the use of all of this knowledge? Because guys, many times these two buds, they don't fuse. So you will have a separate duct from here and separate duct from here. So why duct? Because the guys, this pancreas is an exocrine gland mainly. It has a part of endocrine also, which is coming from the tail. That is your hormones like insulin, glucagon, and other stuff, which we'll study more in your physiology part. But yeah, it is majority a exocrine gland. So it needs duct. Are you getting a point? So you should know that these two buds, they normally fuse. But if they don't fuse, then these two will separate, have separate ducts. And normally this upper duct in a normal anatomy, we call it as a minor pancreatic duct or duct of Santorini, or a minor, and this lower duct is normally called as a major duct or duct of Versung. But in this case, when the buds don't fuse, and that anomaly is known as a pancreatic divisum, in this case, what happens is, because the upper part of the pancreas, which is now bigger, this minor duct over here actually is draining more of the area of pancreas because it is draining head, neck, body, entire body and all. While this major duct area, which is actually the lower one, it is draining the smaller part of pancreas. Okay, more abnormalities will come, but at least you understand that which part is coming from where for better understanding. Okay, so we have all of this ventral bud, dorsal bud, and all this stuff. But remember that okay, it is endodermal first thing, and there are two buds, and they normally fuse around seventh week, week 7, W7, week 7, and then normally it happens. We should know that okay, this is how the ducts, major duct is Versung, minor duct is Santoni, and if they don't fuse, then problems start to arise. Then pancreatitis also may start to arise. Okay, so this was the pancreas, and mainly gut is coming from endodermal. And see, don't worry about the embryology. That okay, you should know the entire one because as we will proceed into the gross anatomy, and it is my habit that before going to any topic of gross anatomy, I will initially give 5-10 minutes to its basic development. Always right. So no matter these things will come again. So for it will go, it'll be good for your revision and the small organs and structures which we may have left in this particular, they will be covered. So don't worry about anything will be left. There will be nothing which will be left. We will cover everything. Now was respiratory system already discussed coming from where? Because the diverticulum from the gut. So it will be basically endodermal. So first line over here is what? Respiratory system is endodermal in origin, but it's lining epithelium only. If someone asks you tomorrow, okay, tell me what happens in asthma, or normally people call it as asthma, it is asthma, correctly pronounced as asthma. In asthma, you will say, okay, there is the muscles are, they're hypersensitive to muscles and all that. And again, somehow the examiner might ask you, okay, can you tell me the muscles of these all asthma and I mean the respiratory system muscles, are they endodermal in origin? Coming from where? They are not endodermal, they are mesodermal. And if tomorrow they ask you, okay, which mesoderm now? Here is the question. They ask you which mesoderm because mesoderm, we all know that mesoderm is having various types. And let me tell you, from an examiner point of view, from me being myself a faculty, every faculty in any subject, be it your medicine, surgery, whatever it is, all of the faculty have some fondness for embryology. So even if they're discussing the patient with you, they might ask, okay, dear, tell me in embryology, you must have studied it is coming from which part? Remember that, right? So if they ask you about these smooth muscles and mesoderm, which mesoderm, what will be your answer at that point of time? Be prepared for that also. In that you will answer. That's the smooth muscles, they come from lateral plate mesoderm. Now, if you remember lateral plate mesoderm, we have studied it has a somatic layer and it has a splanchnic layer. Similarly, at what the extra embryonic mesoderm had, this lateral plate also had. Now, you tell me, guys, out of these two layers, which layer might give rise to smooth muscles? It is the yes. If you are thinking this, absolutely correct. Was splanchnic always means close to the viscera. So it is a splanchnic layer of lateral plate mesoderm which gives rise to the smooth muscles of the gut also, not just the respiratory system. You are getting our point, right? Okay, so respiratory system is endodermal in origin, develops from a diverticulum, called as respiratory diverticulum. Fine, we have, I guess, done a bit of it. Now let us see. We can see the foregut. And here you're seeing a tracheoesophageal ridge, a tracheoesophageal. So from the foregut, you have the esophagus, and from anterior part, we have the trachea. So they are diverticulum actually developed initially, respiratory diverticulum. And you can see the splanchnic mesoderm. What is the splanchnic mesoderm? It is the same splanchnic part of the lateral plate mesoderm. I hope you got the point. You can see it is going along with the diverticulum. This diverticulum is endo, but you can see how closely it is associated with the mesoderm. I hope you got the point. So you have a ridge. So first of all, you have a diverticulum. The diverticulum is nothing complicated. This is a foregut, and here it starts a diverticulum. And the diverticulum will grow, and then from here you have a starting ridge, so that it starts to get a bit separated. Okay, so you have the upper lower respiratory tract. Fine, this is simple anatomy respiratory tract, nothing to worry. And now development diverticulum. Let us just read through it. So develops as an outgrowth on the ventral part of the cranial part of the foregut. Okay, fine. Then it has a groove. Then it has an endodermal lining. Fair enough. Okay, fine. Let us see a diagram because best knows by diagram. In exam also, guys, if you are giving university prof exam, question comes. Say, for example, this topic only, respiratory development. 2-3 diagrams should be clear with you. So therefore, I always say keep on practicing diagrams. If not, since you can view of my previous session also, where a couple of months back I discussed on how to approach or how to guide to write in the exams, or tips for writing any theory exams. Okay, do have a look at it. So always make sure that you know 2-3 diagrams, and if you are not having too much of stuff to write, best thing is whatever you've drawn in the diagrams, try to explain them, and then your common sense will come into play. Okay, so here you're seeing that laryngotracheal diverticulum developed first of all. Okay, and the mesoderm along with it. Then there is a inlet developed, and you have this whole ridge which is developing, and finally you have this whole separate system of this respiratory diverticulum dividing into branches. You have bronchi, bronchioles, like first degree, second degree, third degree, so many branches. They are all endodermal lining epithelium. They are all endodermal. I'm not going into details of it. Again, have a screenshot or notes part. You will have a good details of it. Actually, what I was trying to discuss more in this part, see this diagram. This is again a simple diagram. You can make it. So beginning of 4 weeks over here, what we have this laryngotracheal tube. Then we have the buds, which will start tracheal buds. And from trachea, the bronchi will come, then bronchial, then more bronchi, then finally you have this upper lobe, middle lobe, and all that. So in a matter of 4 weeks, it started from the 4 weeks over here, and here you can see it is around 8 weeks. It has come to into this particular position. More important than that is actually this. Okay, that you understood. Okay, this is but coming now. Again, sir, what is the use? Is there any clinical condition that you can tell while discussing this topic, sir? Is there any clinical condition? Very important, guys. Like yesterday or a couple of sessions back, I was telling you that the problems in all of this embryology now, if you want to see them, you go to either the gynae ward where you have those deliveries which are happening, or in the pediatrics ward or pediatric surgery or simple pediatrics ward. What happens over here? What happens over here is sometimes there is a TOF. You might have heard of it. TOF is, there are two things of TOF that we normally hear. One is the more commonly related to the heart, and that is tetralogy of Fallot. But that is a problem of the heart. Okay, heart embryology is something more interesting. We'll discuss them a bit over here, but mainly in discussing the gross anatomy part. And the other top is tracheoesophageal fistula. What is that? Tracheoesophageal fistula. Now, what happens over here is whatever this newborn child is having, mainly milk, very little amount of it will go to reach the stomach or none at all. Okay, because the esophagus has a blind end like this. And then the upper end of esophagus has a fistula with the trachea. So imagine there's a trachea, that is esophagus, and below you have this as the stomach. So whatever milk this newborn is having, it will not reach the stomach, it will regurgitate, and through the fistula, it will come into the lungs. And it has been a problem. Many newborns have died due to this. They were not diagnosed. Because see, newborn lungs will be how big? Very small lungs. And if it is not diagnosed just at the time of birth, then the initial few feedings and nothing is going into the stomach, the child is keep on crying and he's regurgitating also, he's aspirating also, then the respiratory system will collapse, because now the milk is entering into the respiratory system. How will the newborn child breathe with so small lungs? Therefore, if you look at the MATI postings, wherever newborn child is born, the pediatrician mainly, he takes a small tube and he inserts into the esophagus of the newborn child. Okay, and he checks whether it is going up to the stomach or not. If it is getting obstructed, then there are chances that this newborn child might have this tracheoesophageal fistula. If you diagnose it just at the time of birth, the initial few minutes, good to go. You have diagnosed disease, then you can rectify it. You can do whatever procedure, surgery can be done for it. Because if you are not doing any surgery for it, then obviously nothing can be done, right? So this is one very important clinical indication. Second thing is this over here, the stages. Now, why these stages are important, that I will give you a brief idea, but yeah, these are 4 stages. Remember their names: pseudoglandular stage, canalicular stage, terminal sac, and alveolar stage. These are the 4 major stages in development of lung, maturation of lung. But guys, what is the function of lung? It is function of lungs is not just okay, take in air, take in O2, and then expirate and do expiration, and then expire CO2. Simple. That is not the only function of lung. What along with it goes is this: there are a lot of capillaries, and there has to be a diffusion. There has to be diffusion of gases. There has to be diffusion of gases through the lining of alveoli. Now, this is the matured lung. If you're only taking air, you're giving out air. If that O2 is not going into the system, then what's the use of respiration? No use. So therefore, for this diffusion of gases, you need a very strong alveolar capillary, what we can say, membrane over here, so that proper diffusion can occur. And this is the reason why you need a mature lung. And this normally happens after 6 months of development in this terminal sac stage. So for a obstetrician, when they are planning for a delivery for a pregnant female, they have to make sure that the lungs of the newborn child are matured enough. You also must have heard of a surfactant. And if there's a preterm delivery, suppose due to any reason there's a preterm delivery, then the steroids are injected into the mother so that the steroids do reach the child, and this lungs development is fastened. That is, it is increased at a pace. They have to reach at this terminal sac stage, which is actually after 26 weeks. This is the mature stage. Let us go through it. So pseudoglandular stage is from 5 to 16 weeks. 4 weeks they have the diverticulum, and then this happens. Pseudoglandular, it looks like a gland. Then there's canalicular stage. There is 2-3 points over here, how it develops and all. But main stage is this terminal sac stage, 26. So post 26 weeks, there are chances that that diffusion will occur due to that alveoli and the capillary barrier and the surfactant membrane, all that. Okay, so this is the desired stage, because if their lungs are not matured and the baby is born, then ultimately has to go to the NICU and PICU, NICU, PICU, mainly NICU. Okay, surfactant and all. So that steroid injections also hasten the maturity of the lungs and the surfactant production also. Okay, all these things are given. Finally, we have this alveolar stage. Now, this stage, remember, it is up till 8 years of age. Up till 8 years, yes, up till 8 years. So if even after the birth, the number of alveoli, they slowly keep on increasing. It is not that X number of alveoli were present at birth. So they are the maximum number of alveoli which that body will ever have. No, up till 8 years, the number of alveoli do increase, right? Slowly, and letting. So this is a table over here. So you have pseudoglandulus. Embryonic is obviously embryonic when initial 3-4 weeks. Pseudoglandular, canalicular, saccular is same as terminal sac stage. Sac is saccular, and we have the alveolar stage. So gas exchange over here, see where it is happening at the terminal sac stage. Gas exchange and the proper alveolar development. This is the whole point. This is what clinically any doctor, any obstetrician is aiming for in a pregnant female, that her child's lungs at least reaches this stage. I hope you got the point, the importance of it. Okay. Now MCQs over here, which is not a part of surfactant from type 2, which are the following: not a maturation of lung. Fine, pure say not a maturation of lung. Okay. I hope you got the point. Now coming to the development of kidney. So in the lungs, the bud thing, all tracheoesophageal fistula, very common, and these 4 stages, clinical implication. Development of kidney again. Now, development of kidney, as we discussed, that kidney are mainly coming from the mesoderm, aspect. But in kidney, there are 2 things. What are these 2 things? Let's try to understand over here. Those 2 things are that in kidney, one is the you'll say the secretory part of the kidney. So in kidney, mesoderm, which mesoderm, if I may ask? Think. Give me a few seconds. It is intermediate mesoderm. Now, in development of kidney, there are 2 aspects. One is the, as I was writing, one is the secretory part of the kidney, which is secreting the urine from the plasma. Many nephrons, PCT, proximal convoluted tubules, glomerulus, Bowman's capsule, loop of Henle, distal convoluted tubule, all that. Up till collecting duct, you have the secretory part of the kidney. Now, the secretory part of the kidney is coming from metanephros. Now, what is metanephros? Meta, we all know nowadays. What is meta that social media platform? But what is metanephros? We have 3. We have a series of tube that develop that in different species that develop into kidney. One is a pronephros, one is a mesonephros, and one over here is a metanephros. Normally, these 2 they disintegrate only mesonephros, some tubules are left and some bud remains. But it is mainly the metanephros in humans which gives rise to the secretory part of the kidney. Secretory part of the kidney, that means simple word side, basically a region related to nephron, which is secreting the urine. And that is also known as there's a term known as metanephric blastema. Metanephric blastema. One is the secretory part. And the second part of the development of kidney is the collecting part. Actually, it is going to collect the urine. So it starts from the, say, the collecting duct from where the formation of the urine is ended. Then it goes to your calyces. Then it goes to your say renal pelvis. Then it goes to the ureter, and finally it reaches where? It reaches up to the trigone of bladder. Where? Trigone of bladder, not the entire bladder. Because if you remember, if you recall, when we discussed, the bladder was mainly what? Bladder was mainly derived from endoderm, urogenital sinus, if you recall. But when this ureter open into the bladder, no, then the small area, triangle area, as the ureter is mesodermal, that small triangular area, trigone of bladder, is also mesodermal. So this whole system of collecting duct and all that, that is coming from the mesonephric duct. We have a component known as uretric bud or uretric, yes, uretric bud, right. It is again mesodermal only, but yeah, you have to understand that these two are different things. They both fuse and they form the kidney. But normally it doesn't happen that they don't fuse and all. Why? Because once this uretric bud forms, no, only then it stimulates the secretory part. So till unless there is, you won't ever hear that there is a newborn child having kidney, but no ureter, no bladder, nothing. Just kidney having nephron. Now where will the urine go? So that kidney nephron will only be developed if all this calyces, pelvis, ureter is developed. These actually stimulate the formation of the kidney. You understood the basic part, how the kidney develops. Now let me take you to the notes world, the world of notes, and here you can have some in a format over here. How to write? So notes wise. So excretory part, you have the metanephros, fine. Collecting part coming from uretric bud, collecting part of the kidney, that you should know. Mesonephric, you have some tubules which are left from it. As you have a metanephric blastema and uretric bud. These are two main things that you need to remember: uretric bud and metanephric blastema. Let us remember these two names. Okay. Now uretric bud comes down and down, differential growth. Basically, it is this which will help you understanding. Let me Let me zoom it a bit over here. Okay. Let us see what is being shown over here. So yeah. Can you see this uretric bud? This Wolffian duct is your mesonephric duct. Now, can you see this, some of these, they are condensing all this dots over here. If I may show with, say, this blue color. These dots over here, they are actually, they will condense. And these are the ones, they will actually coming from the metanephros. Okay. So these all condense, and finally, you will see that you have this whole comma shaped body, S shaped body, and you can see this whole nephron which is being developed from this condensation. So basically, what is all this? This is all your metanephric blastema, metanephros. Let me write metanephros, and this is your uretric bud, which is actually coming from mesonephric duct. What is mesonephric duct, guys? Mesonephric duct is again related to the mesoderm, and it is a male genital duct, also known as Wolffian duct. Its other name is Wolffian duct. Another high yield question for your MCQs. The derivatives from Wolffian duct and all. So it is the basically the male genital duct. The male genital duct. What does the male genital duct mean? So what comes out from testes? Epididymis. Vast difference. Those are the ducts which carry the semen and having the sperm, all that from the testes into the prostatic urethra. That is the whole male genital duct system. That is coming from the mesonephric duct. It gives a diverticle known as uretric bud. So main job of mesonephric duct is not uretric bud, though it is also a main, but its name came from male genital duct system. Okay, so try to understand this part. Okay, let us move more. Now there are so many congenital anomalies of pancreas. Many. There are a few which are named over here. One of the common is horseshoe kidney. Horseshoe kidney, it appears somewhat like this. And there's a famous question that there's an artery which is running in front of the horseshoe kidney. Now this is again, should I give you homework, guys? Do it on your own. Suppose this is a horseshoe kidney. I'm sure it is not written over here. Yeah, in front and behind the aorta. They are saying they are not named the artery. So good. This is the artery. Name this artery. That is a homework for you guys. And I urge all of you, at least if you are doing some research academically in this particular questions, answer them in comment box so that we know. Okay, it also gives us a boost so that yes, you are trying hard. Then we have pancake, lobulated kidney, and so many anomalies. The kidney is what we have. Not going details of it. Bladder we already have seen. Basically, two things are there. What are these two things? You have this endoderm over here, and then you have the mesoderm over here. Just remember this, and then again the diagrams will fetch you the problems over here. Now, heart development I won't be discussing over here, but what I will be discussing, because heart development we'll discuss in thorax part. It is actually a huge topic. It can't be discussed in a as a sub part. Okay, here comes. And the question thyroid gland, guys. Now, yesterday or in the previous session, I gave you a question. The question was that when we were discussing the anatomy of the tongue, basically the development of the tongue, there came a term known as foramen cecum. And I asked you over there that, okay, can you tell me that the duct arises from the foramen cecum? Okay, and it gave rise to which structure? The answer over here is thyroid gland. It develops from this thyroglossal duct. So what is glossal? Glossal, again, like lingual, is related to the tongue. Okay, so glossal over here again related to tongue. So there is a thyroglossal duct. If I show you the tongue, suppose it's just for a second, show you tongue like this, and there's this foramen cecum over here. Then guys, here is a duct that is coming down. This is thyroglossal duct. So imagine tongue over here and thyroid gland over here. The duct from here goes down in front of neck, and then it bifurcates into two, and you have the two lobes of thyroid gland, right and left. Again, if you know the origin, then you can understand there can be a multiple congenital anomalies related from the tongue to the neck, which can be common variations also. One, let me tell you, sometimes there is a image also. People have seen cases also. I have not, may not have seen by now, but yeah, people have seen that in the, if you ask the patient to open the mouth and take out the tongue out, then in that patient, in the tongue behind there is a swelling. Now, most of the times it is like, okay, is it a tumor? Is it a tumor now? As a doctor, as a busy doctor, they normally rush it. Okay, have a biopsy done, they have this done, that done. Let us see what it is. If you simply at times may take a history of the patient and ask, okay, is this swelling? Okay, just ask him from when it is. He may say, sir, it is from as far as I know, as far as I know myself, it is from many years. Then if you look at closely, it might be an ectopic thyroid gland. It might be an ectopic thyroid gland, which was from here from the very beginning. Only it is now more relevant, is now more easily seen, and you may have had a incidental finding also. And this ectopic thyroid, as it is in the tongue, we call it as a lingual thyroid. It is not that uncommon. It is a lingual thyroid. So now if you think of it as any tumor or a growth, then you may do a biopsy, and if you are very hurry, then you may remove it also, and patient will have the lack of thyroid hormones. Understand this. So yes, site of origin of the diverticulum over here is a depression from the foramen cecum. Understand this. Because now just have an image over here so that we understand it better. Okay. Okay. Now here what you're seeing is this ventral pharyngeal floor over here, and here you can see that these particles are coming down, and this is ultimobranchial body. We did a topic on pharyngeal arches. In the pharyngeal arches, remember the endodermal pouch. Which pouch was there? Fourth pouch. Neural crest cells came in ultimobranchial body, and finally they gave rise to what? Parafollicular C cells of thyroid. Therefore, it has been shown over here because we are looking at the development of thyroid. Okay, parafollicular C cells of thyroid. Fine. So here you can see, because what is this 1, 2, 3, 4? These are pharyngeal arches. So tongue is also developed from here only. Remember the tongue development, pharyngeal arches. So from here, if you imagine the foramen cecum, then these particles coming down. This is thyroglossal duct tissue, and ultimobranchial body also coming down. And finally, you can see this is whole thyroid gland being situated over here in front of neck. Okay, remember this, at least this part. Many congenital anomalies are there, many. Let me just name a few, or let me give you a good perspective on an important MCQ that comes, and that is your what? In pharyngeal arches development, when we discussed pharyngeal arches in the previous session, I said, okay, the second arch ectoderm comes down and overlaps everything. If it does not overlap the other arches completely, then there can be branchial, not brachial, but branchial sinuses or branchial cyst or branchial sinuses or branchial fistula can develop. That was, where was the location of it? If you remember, guys, we discussed that. The location of this branchial cystosinuses were where? I specifically told you in front of sternocleidomastoid muscle. So location, let me write SCM and anterior to it. Anterior to it. Now that is fine. Now there's one more sinus, one more cyst that is commonly seen in the neck, and that second one is known as thyroglossal cyst. Thyroglossal cyst. Now that is very interesting. Now listen to it carefully. Now tongue is over here, and the thyroglossal duct is coming from the tongue and coming down somewhere over here. We have the thyroid gland. So this is the whole root. This is the whole root taken up by the thyroglossal duct. Clear with me? Okay. What happens is, during this root, there can be small cyst or sinuses that could have developed over here. But thing over here is that this thyroglossal cyst, if it develops, it is near the midline of neck. Because you have one tongue only and one foramen cecum only. So it will be in the midline or close to midline. So it is near the midline of neck, not around the anterior border of sternocleidomastoid. Because see, it can be very tricky. You know, you have swelling over here and you have swelling over here. It might easily confuse you. Which one is what? So they are very near. They are not very far off. And in a small child, this area is itself very small. Again, creates confusion. Now you are seeing a swelling in the neck, somewhere close to midline. It can be in thyroglossal also, can be branchial cyst also. How to differentiate? How to differentiate? Here comes the knowledge of anatomy, embryology, and your, what to say, clinical aspect. How to differentiate whether the swelling is a thyroglossal. I'm not asking for any investigation, simple test. Ask the patient to protrude the tongue. Ask the patient to protrude the tongue. You hold the swelling tightly. Suppose case 1, there's a swelling over here. You hold the swelling. You ask the patient to protrude the tongue out. The patient will do this. Nothing will happen to the swelling. Swelling will remain like this. You will keep on holding it like this. There will be no pressure or no traction on the swelling. It is probably a branchial cyst, because branchial cyst is nowhere closely directly related to the tongue. Second case, a swelling was here only a bit towards the midline. You are again holding it. And then you ask the patient to protrude the tongue. The patient will protrude and the swelling will be pulled upward because it is connected to the tongue directly. You feel the traction going as you will be holding it tightly, and the traction will be pulling that swelling upward. That is a simple way to test, to differentiate. Ask the patient to protrude the tongue. Simple as that. That you can easily do. No test needed. And then you are more or less quite sure that, okay, with my clinical examination findings and my knowledge, I know that this particular child or whatever is having the thyroglossal cyst. See, okay. These are the very famous questions that come in your Viva OC, a university, and more importantly in your MCQs. They do come a lot. Finally comes the placental circulation, though it is commonly related to our what you say, the heart development, but I will try to give you a small picture over here of the placental or the fetal circulation. Basically not placental, but fetal circulation is very important. Okay, just few minutes over here for the fetal circulation. So let me just start over here as a small topic, fetal circulation. Guys, this fetal circulation topic you study in first year, and let me tell you, you'll study it again in pediatrics. All of these anomalies and a bit of embryology, it will come again in your pediatrics, a bit in pediatrics as well as your obs-gynae. A bit of it will come, but our main embryology is in first year. So fetal circulation, how to understand it? See, the embryo is not able to breathe, so all the oxygenated blood is coming from the mother only via placenta. So the oxygenated blood that is coming through umbilical what, artery or vein? It's coming through the umbilical vein, not artery. And mainly which, the left umbilical vein, not the right vein disappears. So there is one umbilical vein left side, and there are a pair of umbilical arteries. What type of blood is carried by umbilical arteries? The deoxygenated blood. Let me just give over here a tinge of blue color, and yeah, deoxygenated blood is by the umbilical artery. So by definition, what is artery? Artery by definition is not a blood vessel carrying the oxygenated blood. Here you are seeing the exception to it. Artery by definition is a blood vessel carrying the blood away from the heart. So umbilical artery is carrying the blood away from the fetal heart. And umbilical vein is carrying the blood towards the fetal heart. So umbilical vein, therefore, is vein because it is carrying blood towards. And umbilical vein is having oxygenated blood, and artery is having deoxygenated. Now here I will just give you a good idea, because again not going details of it, that will do in again in development of heart. Changes which occur and the clinical implication, changes which occur. So suppose this is an embryo and this is an adult. We try to make a table, and what are the changes which will occur for embryo and an adult. In embryo, as we have seen, okay, first change is in embryo, we have umbilical vein. This becomes ligamentum teres in adult. In embryo, we have umbilical artery, and that came in last year NEET PG. And this umbilical artery is doing fine. And this becomes your medial umbilical ligament. Medial umbilical ligament in adult. Then we have over here ligamentum venosum in embryo, I mean fetal circulation. And sorry, not ligamentum, it is ductus venosum. It will become later on. No? It is ductus venosum, and it becomes ligamentum venosum over here. Similarly, we have ductus arteriosus in placenta in your fetal circulation. Ductus arteriosus, it becomes ligamentum arteriosum. Okay, then what else? What else are changes over here? Yeah, we have foramen ovale over here. Foramen ovale in fetal circulation, and it becomes fossa ovalis. Fossa ovalis over here. Right. So these are some of the major changes that occur during the different circulation. But the main point is that okay, we have things are totally different, no? Therefore, as soon as the child is born, it is seen that the child is crying or not, because more crying, more air is going into the lungs, and more blood is coming into the left atrium, so that the foramen ovale closes, the arteries open up, the pulmonary vasculature comes into role. That is the whole point. Why? As soon as the child is born, it is seen that the child cries. This whole development of heart, that is basically done in our forex part. Don't worry. So guys, I hope you had a good, in this 4 or 5 sessions, you have a good idea of embryology. I repeat again, embryology is very, very interesting. Divided it into general and as well as systemic embryology. And the main thing to understand is general embryology, and then obviously systemic. And always do correlate this embryology with a gross adult anatomy. Gross adult anatomy. So that you know. And they're very, very interesting things. I urge all of you to keep your revision to the top end. We keep on revising and do practice diagrams, revise and practice diagrams. If you ask me the books, because yeah, that is a major question. Most of the question comes from books. Standard all will remain standard no matter what you do is Langmans. So, but it is not easier to understand. Yes, I know. Read it 2 or 3 times. Don't make excuses. Try to read it. Okay, give it a shot at least. And if not, then okay, the simple book will be from I.V. Singh, sir. I.V. Singh book of embryology is also fine. But a standard is Langmans, and questions do come from Langmans if you want to have a good hold, because there are a lot of images also in Langmans, clinical images which are given. So do go through it, right? It is a very, very fantastic book. I.V. Singh is not anyway inferior to it, but yeah, for the standard books, standard language, standard diagrams are given in Langmans. Simple as that. If you are not able to understand it after giving a few try, go with I.V. Singh. No problem. Okay, it is your choice. I hope you got the point which I wanted to convey. Right. So that's all from my side, guys, in embryology, and we'll see in the next session. Probably around genetics is what we are going to discuss in the next session. Bye bye. And any comments, do write in the comment box. Take care.